Welcome friends, we are going to discuss Neet PG 2025 pattern questions. Disclaimer, these are not the original questions, these are questions based on the questions being asked in Neet PG 2025. Okay. So section A, general surgery and trauma related questions. The first question is a very easy question and I hope most of you would have answered it correctly. Identify the type of knot. The first throw is 2 knots is seen in surgeon's knot. Surgeon's knot is a very good knot, which is a very secure knot also. When we throw the first knot itself, we put a two throw, then over that we make a square knot. So please understand the granny knot, square knot and surgeon's knot. It's a repeat concept. A square knot, very easy to identify because of the 2 throw. First throw is 2 throw in the first time. In granny knot and square knot, you should know the difference. Granny knot is a slip knot. I used to tell grandma wears colorful saris and slips. Please remember the mnemonic. Grandma wears colorful saris and slips. At the crossing point, you can see here it is blue on the top and red on the top. So different colors is a granny knot or a slip knot. It's not a secure knot. If you put this knot, it will slip down. It is used in special places where we want to put the knot deeper in a cavity. We use this granny knot. So granny knot is not a secure knot. Whereas square knot, the top of the crossing will be the same color. The top of the crossing will be same color on the top. That is a secure knot also. It is secure knot. So any suture you make, final knot should be a square knot. So for example, in a surgeon's knot also, the final throw will be a square knot. So square knot, also called as a reef knot, is a secure knot. Don't forget, granny knot is a grandma wears colorful saris and slips. So different colors, granny knot will slip. Whereas square knot is a secure knot. So there is no need of understanding how to make these knots. That is not essential for a PG entrance exams. Once you become a surgeon, we will explain you how to put these type of knots. So this is a picture showing you a continuous suture which is completed by making a special knot called as Aberdeen knot. So a continuous suture is completed by making a knot with a loop into which we put the thread and take out. That is a Aberdeen knot for a continuous sutures. The first question is an easy question. Surgeon's knot is the easiest of all the images. So identify the property of the suture material shown below. So the property mentioned is for polydaxanone, PDS suture. So please understand, PDS suture is the longest absorbable suture. 100 times asked MCQ. Longest absorbable suture is PDS. It is 90 to 180 days it can take for absorption. It takes up to 180 days for absorption. That is the longest absorption period is PDS. And PDS is a monofilament material. Please remember, it's a monofilament material. And it is nowadays used in trachea repairs, tracheobronchial repair. We are nowadays using PDS. Nowadays for linea alba closure, laparotomy closure also we are using PDS. Instead of proline, these are the places where we were using proline before. Now PDS being a long acting material, we are using PDS in linea alba, laparotomy closures, etc. So the question is asking, which of the identify the property shown below. It's a monofilament material. It's the easiest answer. So what are the other things? See, understand, it is not a non-absorbable, it is absorbable. It is not organic. Organic means naturally derived materials. So what are the naturally derived materials? You know, catgut is a naturally derived material. Silk is a naturally derived material. Nylon is a naturally derived material. These are all natural derived materials, also called as organic materials. So polydaxanone is a material synthesized in the factory using chemicals. What is this braided? Braided is also called as multifilament material. Multifilament material. So you should understand the difference between monofilament and multifilament. Monofilament will be like this. Multifilament can be braided like this or twisted like this. So braided and twisted. So multifilament material, the major advantages is they have a good knotting property. Multifilament materials have good knotting property. Whereas monofilaments have poor knotting property because it will slip. But advantage of monofilament is decreased risk of infection. There is a decreased risk of infection in monofilament material, whereas in a multifilament there is increased risk of bacterial colonization. So bacteria can live between the two filaments and can grow. So bacterial colonization and infection is very common with multifilament material when we use in infective areas. So multifilament material and monofilament material, please don't forget this is a picture of braided material. So the question is very clear, it's a monofilament material. 25-year-old patient had an RTA and was initially conscious but later became unconscious and subsequently died. So until then we cannot come to a diagnosis. Patient was initially conscious, later became unconscious means we will think of, usually many students who wrote this question might think of extradural hemorrhage. Extradural hemorrhage is a hemorrhage where there will be lucid interval. So lucid interval. So lucid interval is a period of consciousness before going for unconsciousness. That is what most of you might have thought. But until you read the next line, on postmortem examination, multiple petechial hemorrhages are seen in the corpus callosum. So I have taken a postmortem image here. You can see multiple petechial hemorrhages in the corpus callosum. So this is a classical investigation. Usually contrast enhanced CT of the brain may show petechial hemorrhages. Petechial hemorrhages may be shown by CT scan brain, but usually it will be normal CT scan. It will be a normal CT scan. So investigation of choice to diagnose this injury is MRI. What's the diagnosis? Diffuse axonal injury. So diffuse axonal injury is a condition in which there will be multiple petechial hemorrhage. I don't think they had a question of diffuse vascular injury, might not be a question because diffuse axonal injury will have a diffuse vascular bleed. So therefore the best answer here directly from Bailey and Lowe is diffuse axonal injury. Because in diffuse vascular injury also you can get these petechial spots. I don't know whether there was two choice, diffuse vascular and diffuse axonal, but the line from Bailey and Lowe says CT scan of the brain shows petechial hemorrhages in diffuse axonal injury. Therefore I am going for a diffuse axonal injury in this question. This is about the classical MCQ. MRI is the investigation of choice for diffuse axonal injury, and diffuse axonal injury patients will go for comatose state. They go for comatose states and they become vegetative for long period. So this is a classical repeat question. In case of a stab injury of the abdomen of the left, patient has left upper quadrant pain and signs of peritonitis. What is the next step? So penetrating trauma protocol. I am writing the penetrating trauma protocol. Please don't forget penetrating trauma protocol. There is no role of EFAST. Please remember, no role of EFAST or ultrasound. There is no role of these investigations. So then what should I do? So examine the patient of a penetrating trauma. See patient is unstable, hemodynamically unstable, peritonitis, when there is a feature of peritonitis, when there is a bowel or any other organ evisceration coming out of the wound. When organ is coming out of the wound, patient is unstable, the low BP, systolic BP less than 90. Such cases you can directly take them for laparotomy. So penetrating injury of the abdomen, patient being unstable, peritonitis, bowel evisceration or any organ omental evisceration, anything coming out of the wound, you should take them directly for laparotomy. Now the point is, in a stable patient, what will I do? In a stable patient, the first thing I will do now as of update as per the protocol is local exploration under local anesthesia. Put a local anesthesia and exploration of the wound. You explore the wound through the where the knife has entered, explore the wound and look for peritoneal breach is present or not. If the wound has entered the peritoneum and you have a peritoneal breach, if peritoneal breach is present or not, if peritoneal breach is present, then I will refer the patient for CECT abdomen. And you keep them in observation in the hospital. Don't discharge them. Keep them in observation for at least 12 hours. You should keep them observation for 8 to 12 hours. Even if the CT is normal also, you keep them in observation for 8 to 12 hours. And if peritoneal breach is absent, you can discharge the patient by putting a skin suture. Discharge, make skin suturing only, that's all. Because it's a superficial injury. The penetrating knife has not entered the abdominal cavity, it is just a superficial injury. Therefore, make a skin suture and send the patient. So if it is gone deeper, you have to observe the patient with the CT abdomen. This is a simple protocol for a penetrating trauma. The patients have sign of peritonitis, immediately you should go for laparotomy, nothing else needed. Wait and watch, CT abdomen, ultrasound, nothing is needed. It's a clear-cut case as per the protocol. Go for a laparotomy if there is a peritonitis, probably a bowel is injured there in the left side abdomen. Okay. So in a trauma, there is a very commonly asked question, what is a false statement regarding the procedure shown below? You can see from the procedure, They have very clearly mentioned this is thyroid cartilage, this is cricoid cartilage. In between the two, there is a membrane called as cricothyroid membrane. So into that membrane, they are doing a procedure called as cricothyroidotomy. So cricothyroidotomy is a name, so picture shown here. So it is also called as needle tracheostomy. 16 gauge needle is usually inserted there and can be used for more than 2 hours is wrong. Through the needle, we have put a needle through this, no, through that needle we pass a catheter. We pass a small size catheter, 3 to 4 mm catheter into the trachea, and through this we give high flow oxygen directly into the lungs. So this cannot be used for 2 hours, you can use only for 30 minutes. If you use for more than 2 hours, CO2 accumulation can happen. So therefore, wrong answer here is more than 2 hours is wrong. So understand this table taken from our material. So done at cricothyroid membrane. Done at cricothyroid membrane, also called as cricothyroidotomy. We insert a needle of 16 gauge Venflan. You can put a 16 gauge Venflan, which is a grey Venflan. We will take a grey Venflan and you can put it there. Okay, put a grey Venflan directly into that, and through the grey Venflan you pass a small 3 mm suction catheter, something like that, and through that you put an oxygen. This procedure is contraindicated in children less than 12 years because they can develop subglottic stenosis. So it can be done only for about 12 years. So maximum we can give for half an hour. Beyond that, if you give only oxygen, CO2 is not coming out, will accumulate and cause hypercapnia. Please don't forget this image. It's a clear-cut question of cricothyroidotomy. So there are 5 questions from general surgery and trauma. Next we are going to head and neck, thyroid, breast cases. Neet PG questions, surgery questions are very easy compared to previous year Neet PG or previous INISET. So easy paper. Some questions I thought whether it was such a easy question. Carpopedal spasm is a complication of. So please understand this question many students wrote as parathyroid surgery. Very clear-cut question. When there is a hypocalcemia, patient will develop carpopedal spasm. When will they develop? When there is a total thyroidectomy done. And the inferior thyroid artery which supplies parathyroid gland is ligated. When the inferior thyroid artery supplying the parathyroid glands are ligated, the parathyroid gland loses blood supply. And causes this problem. Please don't forget this. Causes this problem of hypocalcemia. In parathyroid surgery, unless you are going to remove all the 4 parathyroid, this problem is not going to happen. And in that also, that is not a common complication. So carpopedal spasm is a complication of thyroid surgery. So don't forget this question. Clear-cut question following a total thyroidectomy operation. They will develop carpopedal spasm called as Trousseau sign. And they can also develop Chaustuck sign. Chaustuck sign means when you tap in front of the ears, they will have facial twitching. Trousseau and Chaustuck are the 2 signs of occult hypocalcemia. They are the signs of occult hypocalcemia. Overt hypocalcemia will have tetany. Okay, don't forget that. Tetany is seen in overt cases. So before getting a overt hypocalcemia, patient will have Trousseau sign, Chaustuck sign. So here is a picture showing you extensive pituitary orange involving more than 1/3 of the breast. More than 1/3 of the breast you can see here having pituitary orange. This is a new update from 28th edition. See, usually we always say when there is a new edition coming, there will be a new edition question. So this is a Bailey and Love 28th edition update. When this question was asked from old edition, I will directly go for pituitary orange. Okay, it is a skin involvement. I would have gone for T4B. Please understand, T4D is the answer for this question. T4D in 28th edition Bailey says more than 1/3 surface area having pituitary orange as shown in the picture comes under T4D. Inflammatory breast cancer comes under T4D. So most of you who have not read this update might have answered T4B because T4B is for skin involvement. We have discussed about skin involvement. Skin involvement is pituitary orange, but new update in Bailey and Love is less than 1/3 surface area pituitary orange, ulcer, satellite nodules. So ulcer, satellite nodules, pituitary orange less than 1/3 skin involvement T4B. And I hope you know T4A is chest wall involvement of ribs and all. So chest wall involvement is ribs, serratus anterior, all those things. So T4C is both skin and chest wall. So the important update here is T4D is newly updated as 1/3, more than 1/3 involvement of skin with the putty orange. Subdermal lymphatic infiltration is called as putty orange, is shown here in the picture. Okay, that's answer is T4D. This is an anatomy based applied anatomy come surgery question related to the nerve surgery shown here is submandibular gland. Okay, this is a submandibular gland surgery. So to understand this surgery, submandibular gland surgery, you should understand what is rule of 2. Rule of 2 in submandibular gland surgery. Rule of 2. See, please understand, I will make a 2-inch incision. Below 2-inch incision is made like this, means 5 centimeter incision made just below the mandible, and it should be 2-inch, and I should preserve 2 superficial nerves. 2 superficial nerves, I should be very careful when I am operating because I may injure 2 superficial nerves. They are marginal mandibular and cervical nerve. Cervical branch of facial nerve. These two are branches of facial nerve. So the marginal mandibular branch and cervical branch of facial nerve can be injured. So preserve 2 superficial nerves before entering into the gland. And then after entering the gland, ligate facial artery 2 times. Facial artery 2 times you will be ligating the same facial artery because the course is like that. It tortuously it goes from here to here, then it goes like this. So the course is like this. If there is a gland, above the gland, you can see the facial artery goes like this. So therefore, I need to ligate the facial artery 1 time here and another time here. 2 times I will be ligating the facial artery during surgery. And the most important is preserve 2 deep nerves. What are the 2 deep nerves? And you should remove 2 lobes, superficial lobe and deep lobe. 2 lobes removed. Very important is you should preserve 2 nerves which are seen below the gland. So you can see after lifting the gland, we are encountering 2 nerves here. So the nerves shown here are very clearly in the anatomy material. So this is a lingual nerve which is closely related to deep lobe. This is lingual nerve and this is hypoglossal nerve. So after you lift the gland, you can see both lingual nerve as well as hypoglossal nerve. So these are the 2 anatomical structures below the gland. So the picture from the image was not so clear whether it is a lingual nerve or hypoglossal nerve, but I will say examiners will usually ask lingual nerve only because it is very closely related to the duct and may be injured when you are removing deep lobe. When you are removing deep lobe, you will see the lingual nerve, and very prominently seen nerve is lingual nerve. Hypoglossal nerve may also be visible here. Ideally, the examiner should show you the 2 nerves and they should ask which nerve is being shown in the image. So I hope the image shown here was the same image I am showing here because this is downloaded from the internet, and here is a lingual nerve. Okay, that is having a submandibular ganglion will be attached with the lingual nerve. So ganglion to the submandibular nerve will be attached to the lingual nerve. So the answer here is lingual nerve. So there are 2 superficial nerves and 2 deep nerves can be injured. 2 superficial nerves are marginal mandibular and cervical branch. 2 deep nerves are hypoglossal nerve and lingual nerve. So please understand this question. New question in the exam. This is an old question. Middle-aged woman comes with a collapsible swelling in the neck. On an angiogram, the picture is shown below. See, this is a case of carotid body tumor. Carotid body tumor. The catch point here is carotid body tumor is not collapsible. That's the catch point here, not collapsible. So carotid body tumor will not be collapsible. It is only carotid body aneurysm. If there is an aneurysm in the carotid body aneurysm will have collapsible. Carotid body tumor will be potato in consistency. It is very hard tumor. It is like a potato consistency. It will not be reducible. So the consistency, carotid body aneurysm, if it compress, it may get compressed. So therefore, I am not sure with the image given in the exam. The image I have drawn here is a classical carotid body tumor only showing Leyer sign. This is a picture of Leyer sign seen in carotid body tumor. In carotid body tumor, you have Leyer sign. Please understand, in carotid aneurysm, you might have a similar image, but it is not I could not get the exact image, but if it is a carotid aneurysm, you will see the contrast enhancing into the aneurysm like this. It will not be a minimal, and in a previous image, if you see there is no contrast entering into the carotid body tumor at all. In Lyre sign, what we are having? We are having splaying of carotid artery. Splaying of common carotid artery. The common carotid artery is separated. But if there is really an aneurysm, there will be not only splaying, there will be enhanced lesion. Splaying plus enhancing lesion can be noted in between. In between external carotid artery and internal carotid artery. So we were waiting so far for the case to complete, and we could try. We thought that the questions will be available from the national board itself, and we can come to a proper conclusion from the images. But as of now, the case is going on for more than a month, and I don't think they will release the question answer finally. So therefore, we thought of discussing with whatever we had a recall. So from my diagnosis, this can be either a carotid body tumor or a carotid body aneurysm. But I feel from the history, most of the students told there is a collapsible swelling. From the history, I will go for carotid aneurysm only. Okay. From the history, I will go for carotid aneurysm. I don't think a carotid body tumor will be compressible at all. Nowhere it is mentioned because the name itself is a potato tumor, hard in consistency. So Lyre sign can be seen in a carotid artery aneurysm also if it is in between the two. So therefore, the correct image from the students only can tell the answer. Okay. So please understand carotid body concept. So there are four questions from the head and neck topics. And coming to GIT, there are equally distributed. I saw in this section the equally distributed questions from each specialty. General surgery, general part 5 questions, 4 questions from head and neck, thyroid, breast, and 5 questions from GIT, few questions from HPP, and few questions from urology. Like that, they equally distributed the questions. A very good question setting, I can say. 45 years male with a difficulty in swallowing, weight loss, chest X-ray associated with bronchiectasis with a below X-ray image. No need of any discussion. This is a classical case of bird's beak sign. So bird's beak is a barium swallow finding. What is the investigation of choice for this? Investigation of choice is high resolution manometry. So high resolution manometry will show you the DCI of this distal contractile integrity will be less than 100 millimeters mercury centimeters second, and there will be absence of peristalsis. There will be absence of peristalsis, and integrated relaxation pressure will be more than 15 millimeters mercury in the lower esophageal sphincter, which not relaxes. So this is a classical finding of classical achalasia. So what are the findings of high resolution manometry? Means absent peristalsis, distal contractile integrity less than 100, and IRP more than 15. These are the features of type 1 achalasia. Okay, that is the commonest achalasia. A patient presented with a cancer of the anal canal, which is the first node involved. So this is a classical question. So please understand anal canal cancer. So anal canal, there is a checkpoint in this question. There are two parts. This is anal canal. In this is a columnar epithelium, and this is squamous epithelium, and this is a dentate line. Okay, this is dentate line. See, the question was not clear whether it is from the anal canal, from the columnar epithelium, or from the squamous epithelium, because it is totally different for both. If it is from the squamous epithelium, you can easily write the answer. It will go to superficial inguinal node. It will go to superficial inguinal nodes. So this is a repeat MCQ in Neet super specialty exam. This question is repeat MCQ because cancer is most common in squamous, is in this area. So most common site of cancer in anus is at the squamous epithelium. So most common site of anal canal is at the squamous epithelium. So I will say, therefore, the question is asking the patient presented with the cancer of the anal canal, which is first node involved is superficial inguinal node. That is a catch point. If the cancer arises from the columnar epithelium, so from the columnar epithelium, the cancer will go to the pararectal nodes to internal iliac nodes. It will go to internal iliac nodes. That's the catch point here. From above dentate line, drainage is to internal iliac nodes. Below dentate line, it is to superficial inguinal nodes. That is the first node. First node for each are different. So first node for each are different, but the examiner has not mentioned The patient presented with the cancer, squamous cell cancer. The question should be either squamous cell cancer of anal canal or adeno cancer of anal canal. If it is an adeno cancer, I would have gone, it is arising from columnar epithelium, and I will go to internal iliac nodes. If it is from squamous cell cancer, I will go for superficial inguinal nodes. But they have not mentioned both in the question. But from our super specialty MCQs, the most common cancer in anal canal is squamous cell cancer. So I will go for superficial inguinal nodes as the answer for this question. Fistula in ano, which is A type. This is Park's classification. The picture below gives Park's classification of fistula in ano based on MRI fistulogram. MRI is the investigation of choice for fistula in ano. You can see the fistula pictures. A is a fistula which runs between the two sphincters. So this is a picture of external sphincter, this is external sphincter, and this is internal sphincter. So this is internal sphincter. So between the external and internal sphincter, A is coming. Therefore, it is intersphincteric. So picture A is intersphincteric. A is intersphincteric, B is transsphincteric, C is suprasphincteric, and D is extrasphincteric or extralevator, which goes above the levator ani, which goes above levator ani. So the question point now here is, so in this picture, which are all low fistulas? Low fistulas are intersphincteric and transsphincteric or low fistulas. High fistulas are suprasphincteric and extralevator or high fistulas. So low fistulas we can easily do fistulectomy as an operation. High fistulas will need seton placements. Setons will be placed for high fistulas. So please remember, fistula in ano is a favorite question. There will be always a question related to fistula based on Park's classification, and many times they'll ask question on Goodsall rule. Goodsall rule says anteriorly located fistula will drain straight, posteriorly located fistula will drain at 6 o'clock position. So this is called as Goodsall rule. This is Goodsall. Anterior fistula drains straight, posterior fistula drain at 6 o'clock. Don't forget this Goodsall rule also. So when you resect the ileum, terminal ileum is a place of absorption of B12. So B12 deficiency is seen in vitamin deficiency seen in ileal resection is B12 deficiency. Don't forget that. It's a straightforward question. So coming to hepatobiliary and pancreatic area, there is a question, very commonly asked question called as Strasberg classification. This picture is showing you Strasberg. Strasberg is a classification of bile duct injuries by means of ERCP. So classical picture shown here is the most common type of bile duct injury is, assume this is a right duct, left duct, common bile duct, and this is cystic duct, and these are ducts of Luschka. Please understand, these are ducts of Luschka. Ducts of Luschka are rarely seen ducts directly from gallbladder surface to liver. So it is from gallbladder surface to liver you have small ducts, and this is cystic duct. If there is a leak of bile, from the ducts of Luschka or from the cystic duct, this is the commonest type, and this is type A. Okay, this is called as type A. So type B and C are same injury that is related to aberrant duct. This is aberrant right posterior duct, posterior sectoral duct. This is a duct called as aberrant duct. If I put a clip in this duct, clipped is called as B. If I cut this duct is called as C. So therefore, if I cut the duct, there will be leak of bile. So C will have, cut will have leak of bile. In B, there is no leak of bile. This is called as type B and type C. In Strasberg type B, there is no leak. I have just put a clip in the aberrant duct. In C, I have cut the extra duct. That is an important thing. And D and E are, D is a lateral injury of bile duct, where the bile is leaking from lateral part. This is a lateral injury of bile duct, called as lateral bile duct injury. Lateral bile duct injury. If I injure it like this, it is called as E. So D is lateral bile duct injury, E is circumferential injury. I hope you all would have not done a mistake in this, because this is a repeat question, multiple times already asked in the exam, and every class we discuss this for a long time. So bile duct injuries by ERCP Strasberg classification. A patient with the jaundice, anorexia and weight loss for 2 months. Jaundice, patient is coming to you with an jaundice, and if you examine him, you are seeing a palpable gallbladder. Gallbladder is palpable, soft and non-tender gallbladder. What is the most likely diagnosis? They are just asking about Courvoisier law. A Courvoisier law is a law for obstructive jaundice, whether to say whether that the jaundice is due to stones or due to cancer. It's a straightforward question. If it is due to stones, please understand, if it is due to stones, the stones will be formed from the gallbladder, and if it obstructs here, it will not cause enlargement of gallbladder because gallbladder will be already fibrosed gallbladder. In stones, gallbladder, in a CBD stone like this, if there is a CBD stone like this, gallbladder not enlarged. Please understand this basic point. That's a law. If it is due to stone, gallbladder will not enlarge because gallbladder already is a fibrotic or sclerotic or cholecystic gallbladder. If it is due to cancer in the distal bile duct, if there is a cancer in the distal bile duct or head of pancreas, or in the periampullary cancer or head of pancreas, any cancer in this place can cause gallbladder enlargement. 50 times the gallbladder can enlarge. That can cause gallbladder enlargement. So what all cancer can cause gallbladder enlargement is CBD cancer, periampullary cancer, head of pancreas cancer. These cancers will obstruct the pathway, so the gallbladder will be enlarged. In a gallbladder cancer, the gallbladder will not be so big. Okay, gallbladder will not be so big to be palpable, and if a gallbladder cancer, gallbladder might have pain due to associated stones. HCC also, there will be no gallbladder enlarged. HCC, cancer anywhere proximally will have no gallbladder enlarged. So the answer here is cancer head of pancreas. So cancer head of pancreas or periampullary cancer or CBD cancer. This is a classical question on Courvoisier law. Please go through Courvoisier law. A patient was operated for a bleeding duodenal ulcer. Surgeon accidentally cut a structure posterior to epibloic foramen. See, very complicated question. No surgeon will be so bad to cut a structure posterior to epibloic foramen. Structure posterior to epibloic foramen causing profuse bleeding. So it's an hypothetical question. Duodenum is somewhere, epibloic foramen is behind the duodenum, and we don't go and injure something behind the epibloic foramen. Please understand, this is a pure hypothetical question. A surgeon will never do such mistake anytime. It might be done by only a barber. Okay, no surgeon can cause such injury. That is why I am telling you this is a hypothetical question. So these are the three structures which are seen in front of epibloic foramen. Okay, this is epibloic foramen, is a structure which is connecting a lesser sac. This is a lesser sac to behind the stomach to a peritoneal cavity. Lesser sac and peritoneal cavity are connected by one place. This is a place. Please understand, this is the place that is connecting that. So I can put a finger into that, or I can put a clamp at this place called as Pringle maneuver. We can put a clamp of these three structures called as Pringle maneuver. So what are the structures in front? Means in front we have hepatic artery, we have portal vein, we have bile duct. These are all anterior to epibloic foramen. Then what is behind posterior to epibloic foramen? You can see from the picture, the only structure which is a big structure going posteriorly is IVC. Okay, IVC is the only structure seen posteriorly. Answer is B. So answer for this question is B. The specimen of the tumor shown below. What's the diagnosis from the specimen? The pathology cum surgery question. You can see from this picture, there is a lesion in the liver with a central scar. It's a repeat MCQ. We used to get this question. In CT scan, there is a lesion with a central hypodense stellate scar. This is a common MCQ. This central hypodense stellate scar we call in exams as FNH. So focal nodular hyperplasia is most common in middle-aged women. It's common in middle-aged women, and it is benign lesion. It's a benign tumor. It does not go for malignancy, no malignant transformation. So though adenoma has more history of OCP, FNH also has history of OCP. Please remember, history of OCP conception can be seen in FNH also. So please don't forget, FNH, since it's a benign tumor, it is diagnosed on CECT abdomen. Triple phase CT shows central scar. No treatment needed. Just follow up is enough for FNH. Just keep them on follow-up unless it is causing symptoms. So from the specialty, we had enough number of questions in this exam. CEAP classification. So clinical, etiological, anatomical, pathological classification. You can see in this patient there is an active varicose ulcer. It is C6. C6 is active varicose ulcer. C1 is telangiectasia or reticular veins. Reticular thread veins and telangiectasia come in C1. C2 is varicose veins. Varicose vein is a vein which is more than 3 mm diameter. C3 is edema. C4A is pigmentations, lot of pigmentation in the limb. Pigmentation, eczema, they will come under C4A. C4B is lipodermatosclerosis, atrophy blanchi. C4C is corona phlebitica. C5 is healed ulcer. Healed ulcer in the medial malleolus. C6 is active ulcer in the medial malleolus. So please don't forget, in all these things, I can put a subscript. Subscript A means asymptomatic. S means symptomatic. R means recurrent. This is a subscript I can add to this classification. So clinical, etiological, anatomical, pathological classification. C stands for all this. Subscripts can be added to them. Okay. So this is a classical question. You can see the bowel, entire bowel, small bowel on the left side of the chest, including the stomach is there on the left side of the chest. So this is a congenital Bogdalak hernia. This is a picture showing you Bogdalak hernia. So Bogdalak hernia babies will come to you with the respiratory distress. So what should I do? Protocol in a Bogdalak hernia is these babies with the congenital diaphragmatic hernia. First step is put a Ryle's tube and decompress. Ryle's tube, decompression of stomach. And don't give bag and mask ventilation. Bag and mask is contraindicated. You give intermittent positive pressure ventilator. So connect to an intermittent positive pressure ventilator and wait for 24 to 48 hours. We will not operate immediately. We resuscitate the patient for 24 to 48 hours, and after 48 hours, you can repair it by transabdominal approach. You can repair it by transabdominal approach is enough for these cases. So we can go through abdominal and we can repair it by transabdominal approach. So don't forget this question, congenital diaphragmatic hernia, classical simple question. 7 years old boy presents with progressive non-retractable foreskin, tense white preputial skin. What is the diagnosis? So you can see a white skin here. So white skin is a classical feature of BXO, Balanitis xerotica obliterans. It's a pre-malignant condition. It can lead to cancer penis. These patients need circumcision. Balanitis xerotica obliterans is a clinical condition which can go for cancer. And here is a question called as belanoposthitis. It is usually seen in diabetic patients and immunocompromised patients. It's an inflammation of the prepuce and glans penis. It will be very red and it will be painful. It can go for narrowing of the preputial skin and it can lead to secondary phimosis. And these also need circumcision. Control the sugar and go for circumcision in these cases. This is a classical image showing you paraphimosis. The retracted skin backwards is not coming forwards. So paraphimosis is needs circumcision. After reduction, presently we reduce it, electively we do circumcision afterwards. These are the various other conditions. So urethral meatal stenosis I cannot ask as an image-based question. It needs a video to show there is a stenosis. So this is a Burns question where the patient is having a huge escharotomy done for a circumferential eschar. So circumferential eschar may cause compartmental syndrome. Circumferential eschar can cause compartment syndrome in the limbs and it can cause difficulty in breathing in the chest. It can cause difficulty in breathing, chest discomfort. So such cases we should cut out the eschar as shown in the picture called as escharotomy. It is usually formed in third degree burns. Eschar is formed in third degree burns. Okay, so we need to do escharotomy as a first aid in these cases. So another question from varicose vein, 25-year-old with a 5-year history of lower limb varicose veins. Identify the incorrect statement. So varicose veins, the most common etiology is long standing. Okay, most common etiology is weakness of the valves due to standing for long period. Weakness of the valves due to prolonged standing. That is the main mechanism. Pelvic tumor can cause, but that is not the commonest cause. It is graded as C6. This picture is not having an ulcer, so I cannot say it as C6. It is only a C3. Here only you are seeing varicose veins. Not even varicose veins with minimal edema. Edema is present, so I can mention as C3. Gold standard treatment is sclerotherapy is wrong. The gold standard treatment from new edition Bailey, what is it? It is Evla. I'll explain it, don't worry. It can cause eczema and pigmentation, true. It can cause eczema and pigmentation, true. So varicose vein has multimodality treatments. Varicose veins treatment, conventionally what we were doing? Past 40 to 50 years, they were doing Trendelenburg operation. I hope you know what is Trendelenburg operation, in which we ligate saphenofemoral junction, we ligate the saphenous vein. Then we strip the saphenous vein, strip great saphenous vein. Then you ligate perforators. All these are surgery done by small incisions. So Trendelenburg operation was a conventional operation. In between that, people went for another operation called as sclerotherapy. Sclerosants. The method of creating sclerotherapy is Tessari method. Tessari method, you can create sclerosant and you can inject into the varicose veins and you can make a tight bandage under ultrasound guidance only. This is done under ultrasound guidance. Sclerosant was used for a long period for patients who are unfit for major surgeries. We used to do sclerosants, and for small varices only we used. But everything is now replaced. Everything is now replaced by recent gold standard is. Recent Bailey writes very clearly, gold standard is using endovenous laser ablation or endovenous radiofrequency ablation. These are all day care procedures. Patient comes in the morning, they undergo the procedure and they can go evening. So these are the latest procedures. Endovenous laser ablation, endovenous radiofrequency ablation are the recent gold standards. Please don't forget this. A mass over the right eye is gradually increasing in size over the past decade. What is the diagnosis? The picture shows you a small mass in the external angular. So this is called as external angular dermoid cyst. So sequestration dermoid. Sequestration dermoid is a dermoid which is seen at the line of fusion of epithelium. For example, this is one epithelium and this is one epithelium, and they are fusing. Some amount of skin can go inside and forms a cyst which grows and becomes very bigger like this. And it is very commonly seen in the skull where there are many lines of fusion. So it's commonly seen in the line of fusion of skull. And interesting point is when you palpate, you have a bony indentation. That is a catch point. Bony indentation is a classical feature of sequestration dermoid. It is most common in the skull. In the skull, it is common in post-auricular region. Post-auricular region and external angular region. Don't forget this. Post-auricular and external angular, you have this dermoid cyst. So very important question, dermoid cyst treatment is excision. A patient comes to you with a dry and black fingers like this. So see, as MBBS graduates, you should be able to differentiate a dry gangrene and wet gangrene. I hope you all would have seen wet gangrenes. Wet gangrene means it is due to diabetes. Diabetes with a secondary infection usually get wet gangrene. So dry gangrene are pure arterial disorders. Dry gangrene are due to pure artery obstruction. It may be due to TAO, thromboangiitis obliterans, or a occlusion of artery, any occlusion of arteries. Usually you get this type of dry gangrene. From this picture, it seems it is a case of TAO having a dry gangrene. Raynaud's syndrome. Please, many students who wrote this exam wrote as Raynaud's syndrome. Raynaud's disease is not the answer because Raynaud's disease will have three colors, not the black color. Raynaud's disease have white, blue, crimson red color. That is the feature of Raynaud's disease. Usually they don't have this type of colors. The point is, if at all there is still a chance it can be a frostbite, but there is no clue for it. Frostbite means they should tell the patient got into stuck up in the snow or in the cold and he got a finger like this. That means I can go for a frostbite. Also can get a dry gangrene. They can also get a dry gangrene, but it will not be seen immediately. It will seem after some time. So the best answer here is wet gangrene. So wet gangrene is an arterial disorder. So please go through this NEET PG 2025 based questions. So hope this is clear, and these are the most important recalls from some of our students. Thank you for the session. Bye.